Dear colleagues, welcome to Module 2 of our webinar series brought to you by LUTS in conjunction with the EAU and the EU guidelines. This webinar tonight is on outstanding challenges in medical treatment of male lower urinary tract symptoms and benign prostatic enlargement. My name is Christian Gratzke. I am a urologist from Freiburg. I will be moderating this webinar, and I'm very pleased to present to you two excellent speakers who will present cases of monotherapy for LUTS and combination therapy. This is meant to be as a preparation for our live webinar taking place at March 23rd at 6:30 p.m. Central European Time. This being said, I would like to hand over to Professor Jean-Nicolas Cornu, a very well-known expert in the field of male LUTS. He is one of the experts in the EU male guideline group, and he will lead us through combination treatment in male patients with LUTS. Jean-Nicolas, the stage is yours.
Well, thank you very much, Christian. I'm really happy to be here for this webinar event, and I would like to thank the SFU, the SU, and the EAU for the opportunity to participate. Also very happy to share this event with Tufan and you. So I will present some information about combination therapy, also discussing a case. So these are my conflicts of interest and positions. So I would like to propose you this discussion about the male patient, 61 years old, who comes with voiding LUTS. He has no storage symptoms, and he was prescribed alpha blockers, actually tamsulosin, 3 years ago, and is still taking these pills. He has a feeling of slow stream and the bladder not completely empty, and he complains about 1 or 2 episodes of nocturia. Namely, he wakes up at night with the need to urinate, and this is quite a problem for him. He describes no urgency, no abnormal frequency, and no incontinence at all. When you look at the IPSS, it's 17, and he's quite bothered because the bother score is 4. This guy is sexually active, he has no erectile dysfunction, and he mentions reduced ejaculation since he started alpha blocker medication. So he has no hematuria, no UTI. It's the first time he visits a urologist for this, because it was his GP practitioner who gave him the drug. So when you welcome him at the consultation, you have a uroflowmetry that is showing 156 milliliters urinated. There is a residual. You see that there is a prolonged urine stream. It's quite slow. The Qmax is about 12. He has a low average uroflow, and the shape of the curve is not that uniform. The guy is giving to you a ultrasound with a prostate estimated at the 58. There is a median lobe, but the protrusion in the bladder is not measured. There is no real bladder abnormality, and the bladder wall thickness is about 4 millimeters. The residual is quite the same as you have in the clinic. It is mentioned at 90. There is no abnormality of the kidney and no hydronephrosis. So this patient is under alpha blockers, and he would really like something else because he's not satisfied with the actual situation. So the following options are proposed to the floor here. Would you keep the alpha blocker and add 5 RIs, for example, dutasteride? Would you keep the alpha blockers but add a phytotherapy like saw palmetto, for example? Would you keep the alpha blocker and add PDE5 inhibitors like tadalafil? Would you double dose the alpha blocker, or would you propose a switch to surgery?
Nicola, thank you very much. That's a great case. Before I will ask Dr. Tarkarn for his opinion, can I ask you just one minor question? Do you always measure bladder wall thickness?
So bladder wall thickness is something that's, has been seen to be predictive of treatment response. It has been seen also as something candidate for estimating the bladder damage. If it is too thick, it means the bladder is working too much and is already in a decompensation phase. But as of today, it is not recognized as a firm and reliable predictor of anything. This is a real case, and this was just indicated by the radiologist who did the examination, just measured the bladder wall.
Thank you. Thanks, great. Dr. Tarkarn, maybe you want to share your opinion with us with this case?
Yeah, sure. Yeah, thank you very much. Jean-Nicolas, this is really a very important and didactic case. We have to be very careful with this patient because there is a risk for developing more deficit underactivity with time. This patient has difficulty in bladder emptying, has high residual urine. He has a big prostate with median lobe. So the odds that he is obstructed is of course very high, plus this obstruction may lead to higher residuals and increase the level of deficit underactivity. So therefore, I would like to be very careful with this patient, and I would discuss with him just adding an 5-RI versus surgical treatment. So these would be my two options that I would discuss at the first hand with the patient. I may give him a chance if he agrees with close follow-up with a combined treatment and see what's going on. This would be my first option, but also surgical treatment would not be wrong actually to discuss at this case with the patient.
Very good. Thank you very much. Jean-Nicolas, please let us know what you did.
So actually, when you look at the guidelines, you know that the level of evidence is very high for the combination therapy with the alpha blockers and 5-RIs. We have a very huge amount of literature and now quite a gigantic experience about this combination coming from the well-known MTOPS and COMBAT studies, who have shown that the combination of alpha blockers and 5-RIs is superior to any of these monotherapies for improving symptoms and Qmax. It's also superior in link with what Dr. Tarkan said earlier. It's also better for reducing the risk of acute urinary retention and need for surgery compared to the alpha blocker alone. So the risk of progression is reduced by this, and also the risk of surgery. So there is actually a strong recommendation for proposing this option as an alternative to this type of patients who need more than the alpha blockers in a situation of persistent voiding symptoms. It is recommended for patients with a prostate, I would say, big enough to benefit from this, achieve more than 40 milliliters today to cover both the finasteride and dutasteride option. If you look closer at the data from the clinical trials, and especially the COMBAT trial, where tamsulosin and dutasteride are involved, you could look at the baseline parameters to see whether your patient is about to be much or very much improved. And you see that if you look at the prostate volume for around 60 and an IPSS of a little more than 16, you will have an important benefit for this patient in terms of IPSS improvement on the left side of the screen, and also in terms of Qmax on the right side of the screen. The small stars mean that it is clearly significantly better with the combination therapy compared to the alpha blocker alone, which are the white bars here. So there is some reason to hope that this patient will do really better. This is actually what the meta-analyses available are saying. When you combine the results of these big studies, you see that the IPSS global and also the prostate volume are much more reduced by combination therapy compared to tamsulosin alone as a comparator. But if you look at real life data, if you propose that to every patient, you would see that the persistence rate is not that really important. There is a quite high discontinuation rate with the combination therapy. It also happens, of course, with some monotherapy, but it is quite comparable, as you will see on the right, if we compare all the data we have in the long term for these groups. For the alpha blockers, fibrinogen, and combination therapy, we have less and less people using that with years. But at the right, you will see that it's comparable. One bigger set is the reduction of hospitalization for acute urinary retention, for example, or even for surgeries. This is what we've said before. This slide is showing that in the medium to long term, we have very reliable data showing that the combination therapy in green here is associated to a very lower probability of having events, acute events of retention or surgery. You will see that this benefit is probably mainly linked to the fibrinogen addition because the blue line on the right are closer to the green line of combination. The question is when to introduce that. We always have these patients who become a bit chronic. We see them every 6 months or every year to reevaluate things. This very nice study is a combination of the available data of the RCTs to produce a longitudinal model and see what happens if you introduce the combination therapy at 1 month, after 3 months, after 6 months, 12 months, and so on. And you see that you have better results if you introduce the combination therapy early in the evolution. You would see that if you introduce this combination therapy earlier, you also have less AUR or surgical events. It goes in the same line as we said before. But of course, we have some related adverse events of combination therapy, and this is why could explain partly the discontinuation rate. You very well know the different side effects of each of these molecules, and particularly based on the previous presentation by the Tatarkan. We may consider that the side effect of combination would be the combination of side effects. Actually, when you look at this very recent trial, looking precisely on what happens under combination therapy, you may look that the sexual adverse events are mainly based on ejaculatory dysfunction. All the rest of the domains, particularly erection or satisfaction, are quite comparable to placebo when you look at dutasteride and tamsulosin combination. Another option would be to add to tamsulosin tadalafil. there is actually no recommendation in the guidelines because we have few data, but I think it's interesting to show that to you today. So we have some short-term, very short-term data showing at the two first line of this table that the combination of tadalafil addition to tamsulosin, it does better than tamsulosin alone in terms of IPSS. And in terms of IPSS quality of life, it's at the limit of significance. It's around 3 points of IPSS. And we have also some information that combination of these two drugs does better than tadalafil alone, meaning that this combination may be something interesting. But of course, it will be better in a context of erectile dysfunction. And you have to respect the contraindications of this tadalafil drug, well-known nitrates, potassium channel openers, and some of the alpha blockers categories, and also relating to the conditions of the patients, particularly vascular heart disease. To date, only tadalafil 5 milligram is licensed for the use in BPH, so would be considered, but we miss really long-term evaluation, and we do not have any real information about disease progression. So we need a few more data. If we want to combine alpha blockers and phytotherapy, which was the other last option to consider, we don't have any clear data today. I mean, the phytotherapy itself compared to placebo is difficult to estimate because the RCTs do not use the same endpoints, and we don't have a good evaluation. Probably the effects are modest, but we have few adverse events. It is to note that one recent study has shown that in one sub-analysis of a big comparative study, the combination of some well-known phytotherapy and alpha blockers lead to an improved situation compared to each of the two drugs in monotherapy. So that may be something to dig in for the future. Again, the other very interesting situation would be to have a comparable situation with alpha blockers onset, but not residual voidic symptoms, but residual storage symptoms. And that's actually opened another box of treatment and options. Very usual case in our daily practice, and I will be really happy to discuss that on our next live webinar.
Thank you very much, Jean-Nicolas. That's a great case. Another good teaser for the live webinar. Can I ask you just one question, maybe at the end of this talk, which I think is a general problem. You have a patient who is on mono treatment, and that's always said in these case discussions, patient is unhappy or dissatisfied with mono treatment. Now, patients are very different, and some patients might be dissatisfied after a rather short time. So are there scenarios where you would actually recommend the patients to stay a little bit longer on mono treatment before he switches? Because otherwise you run the risk of prescribing one after the other regimen, and the patient has no time to really experience the effect of the drug.
Wow, this is a really excellent question, Christian. The recommendation we have is to evaluate people at least 3 months after we change or we set a new treatment. I think this is very reasonable, and that's the minimum we have to propose. The other thing is that we have to very well have in mind, as Dr. Tarkan said before, the time of onset of the efficacy of the drug. If we consider alpha blockers, we know that it is a rapid onset of action, and we can maybe reconsider it after 3 months, for example. If we consider the combination therapy with 5-RIs, or if we look at the sexual aspects, we may get more time to get the effect, probably at least 6 months, if not a year. And finally, we also have to wait, but not for too long, if the patient can be candidate for surgery, as Dr. Tarkan proposed to discuss. This decision is never an emergency, except in case of urinary retention, but it has to be discussed within the year, I think.
Fantastic. That was a very good last word. I would one more time thank you both for the presentations. I am personally looking forward to our live webinar, March 23rd, 6:30 p.m. And we would really be happy if all of you would join and you tell your friends to also join. We will have interactive case scenarios. One more time, thank you also for joining us in. Thank you to the EAU and the European School of Urology for organizing this fantastic event, and I wish you all a very good day. Thank you.